Hello everyone, welcome back to my channel. I'm Dr. Amit Kumar Bhanushali, and today I'm going to discuss about the management algorithms for the abdominal trauma. So I have made two videos. The part 1 will include the management algorithm for the blunt trauma abdomen, and part 2 will include about the penetrating abdominal trauma management algorithm. So I have taken reference from this ATLS textbook, and it is the 10th edition, so this is the latest one. You don't have to worry about the reference source. And at the end of the video, I'll be also keeping my notes, just the image of my notes, so that you can just pause the video and just note down the whole algorithm if you wish to. Alright, so let's start the lecture.
So as you can see, this is the whole algorithm for the blunt trauma abdomen management. Okay, so this BTA is blunt trauma abdomen. So according to the ATLS 10 guidelines, most of the time when you'll be posted in the trauma bay in the emergency department, you will encounter patients incoming with multiple abdominal trauma. So it could be due to any reason, like road traffic accident or fall from height, could be an assault, could be any reason. Now according to the ATLS guidelines, they have to follow this protocol. So you will have two types of patients: hemodynamically unstable and hemodynamically stable patient. I hope you understand what is hemodynamically unstable. The patient who are possibly in the state of shock. Okay, so whether they are stable or unstable, we have to do fast. So if you're not aware what fast means, it is a focused assessment for sonography of trauma. Okay, it's basically a quick ultrasound to check the 4 locations in our abdominal cavity. So I made this small diagram of hexagon of a tummy, and you can see I have made a Z here, giving them bullets of 1, 2, 3 and 4. So they have to follow this order. So one is basically having a look at the pericardial space for if there is any accumulation of blood in the pericardium, and second is the Morrison pouch. We are looking at hepatorenal space if there is any accumulation of blood or fluid there. The third one will be the splenorenal space, the space between the spleen and the kidney, and again for the same reason. Now last one will be the pelvic one. This is also to have a look at the cul-de-sac or the pouch of Douglas if there is an accumulation of blood or fluid in the pelvic region. So because this all spots are the most dependent areas, so this first is usually done during the primary survey, and it is used as an adjunct along with other radiological investigations like X-ray and all that. So in case of abdominal injury, fast is very effective. Just in case if there is no fast available in the facility, then you might have to go for a DPL, a diagnostic peritoneal lavage. We'll talk about that later. Okay, so now let's talk about the unstable patient. Once we have done fast, most likely the unstable patient will have positive fast. Positive means there is some blood in either of these location. If there is positive, definitely you have to take him to the OR and you have to go for the exploratory laparotomy. Alright, now in case of stable patient, it's a bit dicey here. After the fast, in most of the cases it's like negative, mostly negative. So patient will be kept in observation for next 24 hours. Okay, so we will be monitoring the blood pressure and oxygen saturation and overall patient's activity. But if in the stable patient the fast count turns out to be positive, then we have to go for CECD. Well, CECD is the gold standard to look for any abdominal injury. So once the CECD is done, we are going to look for 2 things in the CECD. Alright, so this is we are looking for pneumoperitoneum, or we will be looking for free fluid. Now let me show you what pneumoperitoneum looks like on my iPad. So as you can see here, this is the axial view of our tummy, like of the abdomen. So you can see here, there is an arrow here, the white arrow. This represents the diaphragm, but the dark area you can see here, dark area. This is the subdiaphragmatic air. This is pneumoperitoneum. Pneumoperitoneum is suggestive of leakage of air in the peritoneum from some hollow visceral organs like our intestine. So as I mentioned here, hollow viscous organ injury leads to pneumoperitoneum. And if it is seen here, as it is seen positive here, that means the patient has some perforation, bowel perforation, and he needs immediate exploratory laparotomy and fix that perforation site. Alright. Now if there is no pneumoperitoneum, it could be just the free fluid. Now what the free fluid would be, it would be any blood or bowel content, could be anything. So in that case, I will have one more photograph here. So free fluid, in case of free fluid, you have to go for, see if there is a seatbelt sign there, and there is a large volume of unexplained free fluid. Now seatbelt sign is most likely seen in the patient after a road traffic accident, not in every patient, all right, and not after, even after in the road traffic accident, so like head-on collision with the motor vehicle, head-on collision. If it is not there, then there may not be seatbelt sign. So it's kind of a subjective thing. So if you see a seatbelt sign, how it looks. So this is how a seatbelt sign looks like. You see that it's coming obliquely, and other than the abdominal injury, you will also see some neck injury, some chest injury, and then the abdominal injury. So this is the whole bruise of your seatbelt. All right. So if you see this sign, definitely, and on the CT scan you will also see some blood here. You see this. You see this. This is liver, this kidney, and this slightly dark gray area. It could be. This is the blood. Okay. Also, there's one more here. You see this. This is the Morrison's pouch, and you can see blood there. This gray area, slightly darker than the liver, and darker. The kidney is brighter than that blood. So, seeing this, we can again, this warrants the patient to take for the exploratory laparotomy. Why? Because in this case, he could be having a mesenteric tear. The seatbelt sign is suggestive of a mesenteric tear, because head-on collision can cause mesenteric tear, because mesentery is a fixed organ into the inner abdomen. Also, it could cause a duodenal flexure injury, because duodenum is fixed and jejunum is mobile. So that could create an opposite force and perforation or rupture of the bowel. So in that case again, and it's not just the mesenteric tear, it could also be the major abdominal vessels injury that could be bleeding massively within. Maybe the stable patient may initially be stable, but not for long if it is some kind of abdominal vessel injury. So for that purpose, we also keep such patients under observation, just in case if some impeding blood vessels start bleeding again. So in that case, also we have to take the patient for the exploratory laparotomy, right, and fix the injury or the bleeding site. Now the free fluid can also be seen because not just because of this bowel tear or mesenteric tear or something. It could be also due to some solid organ injury. Now the most common solid organ that could be injured in blunt trauma abdomen is the spleen. Now the second one is the liver. Okay, now the new guidelines has updated this. Previously it was liver, then spleen. Now it's spleen, then liver. Now it's then the third one is the pancreas and kidneys. Okay, now we have a separate management protocol for each of these organs. We'll talk about that in a separate video. Okay, so this was whole blunt trauma abdomen management algorithm. It's not that difficult, it's quite easy.